This morning in my remarks, I was underscoring the role of stewardship and a stewardship mindset and a set of stewardship practices that really are about people collaborating across what are our institutional silos that all have unique added value to add to the transformation of the health system, but that what stewardship is really about is leading on behalf of the whole, not on behalf of your own enterprise or your own narrow constituency, and really thinking together about how we can better invest our resources as communities to promote and invest in health. And some of the implications that I drew for the kinds of leadership capacities that we particularly need, first and foremost was systems thinking, that it does not help us to understand only our piece of the puzzle. We need to be developing leaders who are curious about and interested in how all of the different parts work together to promote the health of communities and to provide great care. So systems thinking is one. That's cognitive capacity. The second thing that I argued I think is really critical is that we need relational leaders, and we need relational leaders who are personally driven by values that are larger than just playing their professional role or leading their own institution, but really have values that are about outcomes that they care about and are able to connect with other people in other roles and other institutions on the basis of those shared values. So that's a relational capacity and a values-based capacity. The other one I underscored is that I think we need leaders who see big possibilities, aspire to those big possibilities, and want to take responsibility for bringing them about.
So how can we make sure that we provide exposure either through people or through case studies or textbooks? I don't think it's going to be textbooks, but through ways and essentially to role models of how this works. And the final thing that I would like to say, in terms of health administration education, we typically talk about graduate school. I mean, that's the emphasis, the master's in health administration, MBA in healthcare kind of thing. I'm fortunate enough to work in a place that has a large undergraduate program, and the AUPHA certifies undergraduate programs in healthcare administration. It's a very growing group of educational experiences. For example, at UAB, our undergraduate program is 60% not white at the undergraduate level. We would dream of that at the graduate level. I mean, it's impossible. We're having the pipeline issue is very different for graduate school. I encourage everyone in the room who's doing this kind of work in across populations to think about undergraduate students and undergraduate graduates to come work for you. I know there's some interesting things going on in Chicago. There's another group that specifically targets high-performing undergraduates to get that experience. I think when they see it, that even drives them further to have the motivation and the not to just become a physician, but to become a leader in this process.
Public health is a very broad and really a changing field right now. And we are really kind of in the process overall in our field of taking a look at where things are headed. In education and public health, we've been kind of built around the model that has existed for almost the last 100 years. And really, to this day, it's not too far from what it was, 80 years ago. And that's definitely not great for change and leading the reality that we have now. So, and now really what we see is that, health has to be interprofessional, it's interdisciplinary. There's so many different ways to look at it than how we have looked at it in the past. And there is still, and this amazes me because this is not my perspective at all, but there is certainly a large segment of the public health kind of academic population that really sees the MPH level practitioner as a technician, who's very, very focused and siloed in a very specific disciplinary area within public health. So maybe you studied epidemiology and that should be your expertise, sort of with blinders to the rest of the world. And anybody who has an MPH and has worked in the field for any length of time, and sometimes for no length of time, you are immediately thrust into a leadership position. And even if it's not an official leadership position, you are often the only person with any public health training on an interdisciplinary team. Our graduates are working in for-profit, nonprofit. They're working in hospitals, for pharmaceutical companies, for health insurers, in research centers. There's really no one place where our graduates go to work. And I think that it is absolutely essential that we are shifting our curriculum toward incorporating more leadership and systems thinking, collaborating and partnering. Those are skills that actually can be learned. And there is this controversy about whether or not you can really teach them, or do they just have to learn them on the job. And I am from the camp that you can teach them.
This is actually, I think, a sweet spot for nursing right now. And it's for many of the reasons that Ruth talked about in terms of what she's talked about in leadership. I actually think we have a jump on the healthcare system in general, because we have, and I will just differentiate here between this age-old dilemma for nursing. At what level are we educating nurses? That is still a dilemma. It's shrinking, but it's still a dilemma. So for nurses at the baccalaureate level or above, we have consistently, for the last 25 years, had a really good, solid set of competencies that took nurses in their educational programs across settings, that put them in ambulatory care, that put them in public health, that put them in intensive care units, that put them in managed care situations as part of their clinical experience. So nurses have always been very integrated in their role within larger systems and how those larger systems address patient outcomes to them. So in many ways, I think we speak very well for patient-centeredness, whether that's at local levels or community levels. Interesting little factoid that my public health colleague might know is that if you look at county health outcomes in public health across the country, the counties that do the best are the counties that have clinical leadership. And in large cases, those are nurses. Some of them are physicians, but many of the particularly smaller counties, their leadership is a nurse, just because she grew up in that. She was a public health nurse, she lives there, and she stayed there forever and ever and ever. So much of what you talk about when you talk about things like stewardship and collaboration and systems thinking, I think really has been bred into nursing education and has been a big piece of our competencies. And
so I have just a couple reflections and questions about that before and we can go into innovations that you're proud of and that you think are moving in the right direction. But as I was listening to you describe what's happening in your programs, I think there is a lot of progress and movement in most professional education to teach teamwork and to obligate people to work together closely in teams and to learn to collaborate with diverse colleagues and to accomplish things together. I also think there's increasing emphasis on leading change and the competencies that you need to articulate a vision and to identify, potential partners and build relationships. But all of that strikes me as still dominantly about doing those things inside your own organization and with people who serve similar functions to you. And where the slippage is in learning how to collaborate with people who are from completely different parts of the system, and learning how to lead change when you're not even talking about your own organization. You're talking about something much larger and trying to figure out purposes together that will shift a bigger system. Is it asking too much of professional education to work on those capacities too, or can you do it in that context and
No,
learn about this larger
it's
stuff?
not. And what comes to mind for me is that some of this education can happen at when people are in their 20s and they're getting a master's degree. I think more powerful opportunities are when you try to teach that at someone later in their career. I mean, I think we need to do both. I'm not saying we are excused from it. We have executive programs where people are working professionals who are getting degrees. We have an executive doctoral program for people in the C-suite. And I think what you see learning in that fashion, they understand that's what they don't know how to do. And in fact, I think some of the younger students know how to do that when they're younger and more idealistic and they don't see colors and they don't understand profit margins yet. I mean, they haven't been ruined by us in some ways. You know what I mean? Do you know what I mean? They haven't been, ruined is the wrong word. They haven't been programmed to think about my organization, my success. And so I think what we have seen across many programs, but that this later in career learning that I think is important. I think it's too much to ask that you learn everything you need to learn when you get your master's degree in whatever it is, or your degree in whatever it is. And so I think what we would call that is lifelong learning, right? I mean, we would say we're trying to create a group of people who are gonna be lifelong learners. I think we all say that. I think there are places that actually offer kinds of programs. I think we together need to be offering more kinds of programs. I think there are some fellowships, like American is Essential Hospitals has a fellowship program. I mean, there are some post-career, I mean, not post-career, senior level career opportunities. And I think there's something to be said for that. I mean, that's both my own, that's really mostly Christy Lamac's opinion, but it's what I've seen over the years. I also want to say, I would also challenge you to say, and we've been talking about this at NCHL, in the last couple of days with board meetings and lens meetings. There's a part of me that says, if you are a good leader, you understand stakeholders, and it doesn't matter who those stakeholders are. In other words, I think there's some just not so great leaders sometimes. I mean, in other words, if you look at people who do this really well, and you see hospital executives who could just run the whole thing. I mean, they think they could. But they understand that I'm going to take the back seat, and I'm going to sit in the room, and we're going to check our organizational identities at the door, and we're going to talk about what this community needs. I mean, we've seen that in practice. And that, to me, in some ways, that's effective leadership. It isn't effective community health leadership or transforming. It's really having a clear picture of what the goal is and who we're on behalf of. So there's a part of me that thinks it really isn't special. It's just people who are really good at their job and are committed to doing the job well. But that's, again, that's an opinion. I'd be curious.
I just want to, I think, probably affirm what Christy just said, and I will just give you an example in Chicago, and this is not nursing related, so sorry, but I can't just stick with my people, even though they're wonderful people. So Chicago is doing a massive effort around the community health needs assessment process. I mean, massive, and I don't know if you guys have had the opportunity to talk about that while you've been here, but they have brought together any number of hospitals and health departments on the needs assessment piece, and then a smaller group of hospitals just in the city on the what can we do, why, if we all have obesity prioritized, maybe we could do something together, which is a huge thing around checking egos at the door and deciding what we want to do for the betterment of the city. I think there's always a tension. I mean, nobody can spend all their time doing that. Everybody has to answer to somebody, as Bob Dylan said, and it's usually your boss or your board. But I think that it absolutely can be done by people who do just what Christy said, who are able to define stakeholders, bring them in, and figure out how to make this a win-win for everybody to look at that larger picture.
Well, and this is a really different example, but it is something, and this is beyond public health, but this is something that the specialized accreditation community has been looking at actively. Many of you have probably heard of HPAC, which is of IPEC. IPEC is what I'm talking about. The Interprofessional Competencies. Those organizations, which are 6 health organizations, associations, develop those competencies. They're now looking to expand the group beyond the 6 health professions into other professions that wish to join. On the accreditation side, we have a kind of a separate group called HPAC, which is Health Professions Accreditation Collaborative. So those 6 parallel organizations, accrediting organizations, are actually together looking at interprofessional education among our accredited schools and programs, and looking at what kinds of standards that we could, and this is a long, hard process, but what could apply across the professions at the accreditation level as well.
Last question on the competencies thing, and then let's talk about some exemplars. Christy, I was struck by your remark that first of all, that kids come in with passion and then get deflated by
Yeah.
reality, but also the notion that we need evidence of what's possible. You know, one of the things that we've been up to in Rethink Health is just a pulse check of the field and looking at, you know, who's really far out there on regional health system transformation, and we cannot
No,
find any
yeah,
examples of fully transformed regional health systems that are genuinely designed to invest in and produce health and that are providing care at sustainable cost. There aren't exemplars out there. So part of what we're doing is we're asking people to take a leap of faith that something amazing actually is possible and to lead into that in a really emergent, inventive kind of way. Can we set people up to, in their 20s, to expect that that's what the leadership job is, and that, that finding a shining example in a fully developed model is not going to answer the
Yep.
question what's possible, that maybe they have to do that.
Yep.
So what do you think?
Yeah.
I would, and this may be heresy, and I apologize in advance for heresy, but I think that with all of our focus on data and the importance of data, and I am not denying that it is important in big data, I think we've lost sight of the fact that we don't have evidence for everything, that we're always going to have to be a little bit on the edge there, that evaluation is really important, that we can be creating the models and collecting the data as we go and not looking for it to come down like on perfectly formed, that we can just adapt to our intervention. And I get a little frustrated sometimes with, particularly in the public health field, I think, where the evidence is not as robust as we would like it to be. But that's okay. That's what we're working on developing, and that's what you work in teams on stewardship kinds of things to look at developing, things that are larger than us and are still in process. That's kind of the exciting piece for the young folks. It would be a lot less exciting, I think, to have them
It was
come
all
in and say,
figured
here's
out.
the cookbook,
Yeah,
just do
yeah,
this.
Yep.
Could not agree more.
Yeah.
Absolutely.
So what have you guys seen in yours or anybody else's program that you think is really innovative and inspiring and that can teach us something cool about developing leaders for the future?
Well, is it okay if I go again?
Yeah, go ahead.
All right, I'm on this side, right? You read left to right. Okay. First of all, thinking about this, I was realizing that, yes, we have to collaborate across communities. We also have this interprofessional within healthcare.
Yeah.
If you just stay in healthcare or in healthcare and public health, you have to collaborate among different disciplines. And so I think for us in the graduate health administration world, we're focusing on both of those levels. I mean, some of the innovations, okay? And I know I think one of them is a precursor to the other. So one of the things that I know many universities are doing is they have these IHI open school models, so the Institute for Healthcare Improvement. And so while it's focusing on healthcare improvement, it's getting together nurses, doctors, dentists, public health people in the same campus when they're in school. And so, for example, at different places that I have been, I've seen them work in different ways. Sometimes they work only in the hospital on an improvement project. Sometimes they adopt families in the community. I mean, it sounded a lot like what we heard of on the AMC project on the hotspotters. In some places, the collaborative adopts families that are underserved in some way and figures out how to serve them. So I think that is an innovation. If everyone was doing that, I think we'd all come out of school with a different view. The barriers tend to be those of us who are faculty. We train people to think in silos because that's how we think. That's where our money comes from. That's who we answer to, right? Is within our silos. So that's part of the challenge. Another thing that we have done in our university is embrace heavily the use of simulation. Both clinical and non-clinical, and I think that does provide an excellent opportunity to learn systems thinking. And one of the ones that we use has a very community orientation flavor to it, but it's about change management. But you see the implications of the change. Another thing that we've done is to try, that I think is innovative, is to take one community and use it throughout our curriculum. Turns out there's a textbook, it's called Middleborough, that someone wrote. I wish I knew the authors' names. I don't know their names. But Middleborough is a set of data, and it's a story. And we start in our health systems course and say, this is the U.S. healthcare system, this is Medicare, this is Medicaid, this is public health. And they look at Middleborough. And then they go to the next class, next semester, and it says, this is the finance course, and we look at data from Middleborough. And then this is the class, how are you going to move the dot on health? And so they focus on one community, not just in one class. And I think that is innovative, and we've got a group of schools who are doing that are having great experience in doing that. I know it sounds minor, but I do think it's changed the way that people think. And then finally, we do at UAB, and I know other places do an interprofessional thing during what they call residency prep week, but it's the physicians, nurses, health administration students, pharmacies that are getting ready to go out into the real world, and they do a series of simulations, and many of them include needs of poor people, and what are you gonna do for the patient when they leave the hospital? I mean, so it's, at least it's, I don't wanna say many, at least one has that focus. So it's not just, you know, a drug error simulation. I mean, it goes beyond that. So interprofessional work, I think, is important. So those are a couple ideas.
So I have just a couple of what things that I'm really proud of, what I consider to be innovations, and many of you might not consider them innovations. They're not necessarily new, but the issue of the evidence base. Oh my goodness, so I talked about how we're trying to transform our curriculum into something that can serve us moving forward, and there has been much need for evidence base, because what is wrong with what we're doing? It has worked just fine for 100 years. Yes. So why should we change anything? And so our field just recently did its very first, I know this sounds crazy that just happened, but its very first job task analysis, which got really incredible response rate, got really incredible data about what people in public health are actually doing on the job. And they rated, I mean, if any of you have participated in these things, they're not for the faint of heart. It's a survey that takes about 45 minutes, but they rated 200 job tasks, public health possible job tasks, and talked about, do you do this in your job? And if you do this in your job, how important is it to your job? So we got all of those data. So now we actually know in public health what people are doing. So it only makes sense that you would train them to do what is needed for them to do in the field. And also, interestingly enough, it turns out that what was found in that job task analysis mirrors very, very closely what people have been writing about and saying, you know, sort of from their gut, is what the community needs its public health workers to do. So we're really excited about that. The challenge there, and I had to laugh, but it's really faculty. I mean, they were trained in a very siloed way. They don't know how to teach sort of these cross-cutting skills that are what people actually do when they go into the workforce. And so there's a lot of resistance there, and I get that, but the other option is to do nothing. And that's not an option as far as we're concerned. So, and then the second thing is, again, the MPH has been the primary entry-level degree for many, many years. We just began, we're doing our very first site visits right now, but just began to accredit at the baccalaureate level in public health. That is growing leaps and bounds on college campuses. Public health majors are just exploding. The students coming in are excited. They see public health as a way that they can change the world, but they also may not be intending to pursue further education in public health. They may be your future lawyers and physicians and nurses and physical therapists, and whatever they do, it doesn't matter. I hope they become legislators, but that's my big dream. But no matter what they do, I believe that is such an important way to get health in all policies and health in all professions, is to get that basic value, that value sense instilled at a very, very new, unblemished, excited age. And so those are probably the two things that I'm most excited about.
So I want to just commend both of those, or agree with what the two previous people said, particularly the interprofessional education and giving people time on task and time. It can be very formally done, but it can also be just, you have to learn to work and play together in some way, even if it's adopting a family or decorating something for Halloween. It's just the idea of meeting people outside of your particular field and learning to work with them. But the thing that I think I'm most excited about in nursing, and it's going to sound a little prosaic, but it's, at least for us, it's not. We've been really formalizing and pushing academic practice partnerships with our academic side, and with our practice side for that matter, with AO&E and other groups. And we have an entire way that we try to guide people through developing in them, and it's really back to that, sit down as faculty with your clinical partners and try to figure out a win-win here. We have been assuming for years that we just wanted you to help us educate our students, and we would put them in your place and you would do what you need to do to accommodate us, particularly in public health, which is my background. I can't believe the kinds of things health departments would do, and put up, their very valuable time of their nurses to something that got them absolutely nothing except for maybe a sense that they were helping educate the next generation, which is not trivial, but when you're overloaded with work and understaffed, and then we're putting additional things on you. So we've really been pushing faculty to sit down and negotiate win-win possibilities so that, okay, we will take your students, but in addition, we need some help on evaluating this, and there's got to be some faculty member who needs a scholarly project related to evaluation that could do this, and when it all comes out, we're all gonna have our names on the publication and the presentation. Or we wanna educate your students, but we need them to do this. So for example, at Rush, the city of Chicago has embraced a curriculum across all grade levels of Chicago Public Schools for teaching sex ed and kind of assertiveness training around sexual health. That's a huge thing, and they want eventually the teachers to do it, which is another huge thing. Rush has actually taken on, as part of our clinical, we're doing 3 schools with our students. It is a tremendous opportunity for our students. They learn more by engaging with 8-year-olds and 10-year-olds and 14-year-olds about how these kids make decisions and what they think about this, and really how you negotiate health information with your clients. Than almost anything else, and it's helping CPS in a very small way, but it's a win-win. There's 3 schools they don't have to worry about. So I think that's the thing I'm most excited about, is really intentional, well thought out, win-win organized academic practice partnerships.
Thank you. Do we have time for a question or a reflection or two from the group, or maybe one? With your permission, could I trouble you to put up the last couple of slides that I had there? I'm not going to go through them all, but I want to offer you guys a resource on the subject of innovations that we're proud of. Rethink Health, if you flip forward a couple of them, has recently produced something that we're calling the Stewardship Guide, which is all of the best of the tools, cases, materials, videos, and examples we could amass that really are intended to enable the development of regional collaborative leadership for health system transformation. It's a very multimedia set of materials. It's all available on the Rethink Health website. It's available to all of you for free. We hope there are lots of things that you find in there that are useful to you. It really is focused on developing this cross-organizational collaborative change leadership capacity that we have been talking about, and this is our best shot at amassing some really cool tools and links so far that all of you might find of service to you in your work. Could you just page it forward to the last one, which will give everybody a picture of what it looks like. It's an online resource, and then there are some cards that we've created around here if you want to take a copy of one home, but it's all rethinkhealth.org/stewardship guide. Stewardship. Thanks, Al.
Thank you.
Great. Thank you guys so much for that great conversation.
Great job. Putting a finishing touch on our programs. 2 busy days, starting with a challenge from Ambassador Lewis at a very high level, down to what we're actually doing in communities to make change in our healthcare systems and better health for our communities, and to the training of our professionals going forward. So friends, thank you for joining us in this year's NCHL Human Capital Investment Conference. In the next couple of months, NCHL will be rolling out its 2016 National Health Leadership Survey. Then next November at this meeting, we will recognize for a second time the Best Organizations for Leadership Development, our BOLD Award. We hope you'll join us at the Ritz-Carlton, Chicago, next November 15 and 16 for next year's conference. We do not have a lot of evaluations back yet, so I'm going to harp on you one more time to pull out those purple sheets and give us some feedback so we can meet your programming needs in the future. And with that, I'd just like to say thank you for coming, and for everyone and for all the sharing of ideas that has taken place formally and informally. Particular thank to the NCHL staff who've done a great job. and all our presenters. Best wishes for a happy Thanksgiving week and safe travels.